Hello, everyone, and welcome to the Clinics Review Articles podcast series. I'm Carrie Holland, the managing editor for Infectious Disease Clinics of North America here at Elsevier. Infectious Disease Clinics is a quarterly publication consisting of review articles focused on a central topic related to infectious diseases. Today, we will be discussing the current September 2024 issue dedicated to advances in the management of HIV, guest edited by Dr. Paul E. Sachs and Dr. Daniel A. Solomon. Dr. Sachs is Clinical Director at the Division of Infectious Diseases at Brigham and Women's Hospital and Professor of Medicine at Harvard Medical School. Dr. Solomon is Assistant Professor at Harvard Medical School and Associate Program Director at Massachusetts General Brigham Infectious Diseases Fellowship. Also joining is Consulting Editor Dr. Helen Boucher, Dean and Professor of Medicine at Tufts University School of Medicine, and Chief Academic Officer, Tufts Medicine.
Hello. Delighted to have Drs. Sachs and Solomon here to talk about the most recent edition of Infectious Disease Clinics of North America, focused on the treatment of HIV. Welcome to you both. I would love to start just at the top with two questions. How did you decide to organize this issue and select your topics? And how do you want us to talk about the drugs? Generic name, brand name, or both?
Well, I can take the first question. Paul, why don't I leave the ART question to you, if that's okay?
Yeah.
Thanks again for having us on. So as we wrote in our introduction, Paul, my dear colleague, gave this amazing talk a few years ago on the history of HIV spanning 40 years, from the first case of pneumocystis pneumonia in the 1980s all the way through turning a almost universally lethal disease, fatal disease, into a chronic disease. And what we wanted to do with this issue is really pick up where that talk left off and think about what are clinicians facing right now in practice and how can we make this useful for people who are caring for people with HIV. And what's on the horizon? What are we looking forward to? So with that in mind, we thought about a couple of topics that were really related to treatment and prevention, including the pipeline of antiretrovirals. And then in the second sort of middle section of the issue, we talked about comorbidities in an aging population, cardiovascular disease, cancer, weight gain. And then finally, we took a look at some special populations, people who live in jails and prisons, people with substance use disorders, and took a chapter on the epidemic of HIV in the South, which southern United States, which looks a lot different from elsewhere in the United States. And then at the end, we have sort of a medical education article that talks about training the next generation of HIV physicians, given sort of the landscape that we outlined.
The medications, I've joked that one of the hardest things about being an ID specialist is learning the names of HIV drugs. And there's a reason why, and it's because we HIV specialists refer to them interchangeably with three names. We have the generic name, the brand name, and the three-character abbreviation. And to make matters even harder, the three-character abbreviation might have nothing to do with the actual name of the drug. So, for example, one of the most commonly used medications is M-tricytidine, which is abbreviated F as in Frank TC. And you'll notice that M-tricytidine does not have an F in it, but that doesn't change the fact that that's how we abbreviate it. But I don't really care. This is all our common language. Feel free to refer to them however you like. And I would echo Dr. Solomon's comments that we chose the topics based on what clinicians are facing.
That's great. Well, thank you both. And I think that as I looked at your edition and reflected, it's just incredible to see that we went from a time when Dr. Sachs and I were starting out, when we had no drugs and then one drug and drug added on one at a time, and crazy regimens our patients were on, waking up in the middle of the night with alarm clocks, to really, for many patients, we only have to know about one drug and it's a chronic disease and they do great. That's sadly not the case for so many patients, and I really am grateful to you for calling out the issue of both special populations and the regional variation, and just would note that it's very noteworthy and tragic that those special populations are special and that regional difference is regional because of the social determinants of health and because in many, many cases, those persons are not afforded access to the care that they need and deserve. So thank you for calling that out. So let's dive in and talk about something that's a very common question for those of us in infectious diseases and who practice HIV, and that is switching, right? So for many patients, it's almost one and done in 2024, but there are many people where that's not quite so easy. And so, why is it important to have the detailed review that you all presented on how to switch ART, and what are the core principles that you think about in making that determination?
Great. Thanks for the question. So I had the opportunity to write a review on how to switch ART with one of our senior fellows, recent graduates, Dr. Basak Lima. And I give a talk to our HIV fellows at the beginning of fellowship about how to select an HIV regimen. And what I always hear is, when is the answer not Biktarvy? And so, while many people are stable on a 1 pill once a day regimen, there are several reasons why people may need to switch. And I would put those in two major categories. The first category is people who do not have virologic suppression on their current regimen. And the reasons for those are many, although usually it's related to issues around adherence, but it may be inability to tolerate or absorb the medication, drug-drug interactions. The regimen is not achieving our goal of viral suppression. So that's category number one. Category number two would be people who have achieved viral suppression, but they want to switch for another reason. They don't like the way that the medication makes them feel. They have side effects. They don't like taking a pill every day. The pill's too big. And so those are actually two different populations. But some of the core framework that we offer applies to both. So when getting ready to switch, we think about compiling a cumulative genotype and ART history. So just what they're on now is not enough. We need to know what they've been on in the past. Review of comorbidities and drug-drug interactions. A big one that we see is advanced renal disease, advanced kidney disease. Are there medications that we want to make sure we avoid? Obviously, we're doing a careful review of patient preferences and barriers to adherence. And then after we switch, it's really important to bring them back and say, how are we tolerating the new regimen? Is it working? And so, as I said, two different populations, but a similar approach.
I would say the biggest issue that comes up now, the most common one, is people who are considering switching to long-acting injectable cabotegravir rilpivirine. And you really do have to provide education about what this entails. It's not a simple matter of the patient saying, I want to switch to the shots, and then you just send a prescription to their pharmacy. This is still a provider-initiated treatment, provider-administered treatment, I should say. So they have to come in for their injections. There are injection site reactions. And I think probably the hardest thing for people to understand is that even if they're 100% adherent to the schedule of their injections, there is a non-zero chance that the regimen will fail, and that the regimen will fail with resistance to both integrase inhibitors as well as non-nucleoside reverse transcriptase inhibitors. And that kind of dual resistance is really to be avoided. So how to convey that risk? It's very small. It's about 1% of people on treatment. But before people go into the treatment, they just have to understand it. So it really puts the onus on the clinician to make that counseling clear. And that's something that Drs. Solomon and Basak Lima cover in their review.
Yeah, thanks to you both. And Dr. Sachs, so just to follow up on that, so education, vitally important. Can you say any more about the types of patients in whom you would consider and not consider switching to the long-acting regimen?
That's a really important question. So the clear no's are people who have resistance to either of the two drugs. And the most common is that they have resistance to rilpivirine, which is a non-nucleoside reverse transcriptase inhibitor. And those drugs have been available since 1996. So not surprisingly, there are quite a few people who have resistance to those agents. The second group I would avoid doing it in is people who are virologically suppressed currently on ART, but not so great at coming in for their scheduled visits. They're good at taking their pills. Every time you get them in for labs, they're fine. But you know what? Their follow-up isn't so great. That is a group that makes me very, very concerned. And then finally, a group I would generally avoid it in is people in the category that Dr. Solomon mentioned, which is people with viremia. This is not always. There are rare exceptions where this is the right choice for someone with viremia. But the vast experience with these drugs is in people with virologic suppression. And if people have poor adherence to their oral ART, they're probably going to have poor adherence to this as well. And so you have to redouble all efforts to get them virologically suppressed before going on and switching them to injectable ART.
Great, thank you. And so before we leave the switch question, would either of you like to comment on your sort of most preferred two drug regimens to switch somebody who is suppressed and switching for a different reason, whether it be side effect or what have you?
Sure. I can answer that question. So oftentimes we're switching to two drug regimens to decrease the cumulative drug exposure. And the regimens that are best studied are those that avoid the use of tenofovir. So people who have underlying bone disease or kidney disease, sometimes we try to avoid a tenofovir-containing regimen. So dolutegravir 3TC or dolutegravir lamivudine, the brand name is Dovato, is a well-studied regimen that is able to maintain viral suppression in people who do not have resistance to NRTIs or integrase inhibitors. And then similarly, dolutegravir and rilpivirine, which Dr. Sachs already mentioned, is another regimen that avoids the use of tenofovir. Importantly, these regimens should not be used in people who have hepatitis B infection. The tenofovir is a really important component to treat hepatitis B. So if we're going to be switching off of a tenofovir regimen for people with hepatitis B, we need to add a drug that would treat the hepatitis B. And this is true for the injectable cabotegravir rilpivirine regimen as well.
It's a good point, Dr. Solomon. I should have mentioned that. Chronic hepatitis B is a reason not to switch someone to injectable cabotegravir rilpivirine.
Great. But would you switch from tenofovir to TAF?
Well, tenofovir disoproxyl fumarate got its FDA approval in 2001. And initially, it was so much better tolerated than existing NRTIs that practically everyone switched to it. And I remember hearing somebody said, hey, this is like putting someone on, an H2 blocker. It's so safe. Well, it turns out over the long haul, it's maybe not so safe. It does cause bone demineralization over time. It does cause renal disease in some people, especially those who have renal comorbidities or are on boosters, because boosters of any sort, PK boosters, raise the level of tenofovir by about 30 to 50%. So tenofovir alafenamide is a much safer from a renal and bone perspective drug than tenofovir disoproxyl fumarate. It's a smaller pill. It's just as potent. It's just as active against hepatitis B. The strange downside of switching people to TAF from TDF is that it turns out that in hindsight, TDF was suppressing weight gain. And by TDF suppressing weight gain, if you take that away and replace it with TAF or really with pretty much anything, you end up having a significant proportion of the people will gain weight. And as you are aware, in our society, there's an obesity epidemic, and the obesity epidemic gets exposed when you take people off tenofovir DF, as in put them on TAF.
Yeah, this is great. So this is a great segue to the discussion and the chapter about weight gain, because that has become a pretty hot topic that you both know extremely well. And so I have a couple of questions. One is, why you chose the topic, which you've already covered some, Dr. Sachs. And how do you suggest we measure weight in 2024?
Well, I think we selected the topic because people really care about it, right? We see this in practice all the time. People go on ART and they gain weight. And I think there are a lot of reasons for that the authors in the chapter, Dr. Balin and Dr. Kuth outline. There's the secular trends. We're seeing more obesity. Many times when people are diagnosed with HIV and they come into care, they go on ART and there's a return to health syndrome where all of a sudden they aren't working so hard to fight the virus and they gain weight. And sometimes people, when they come into HIV care, also get connected to other services like access to food. But we know now that there is a component of weight gain that's directly related to ART. And we also know that not all ART is created equal. So maybe Dr. Sachs, I'll turn over to you to outline sort of the key components here.
Yeah, we first got wind of this controversy when many people were treated with a regimen called tenofovir, emtricitabine, efavirenz, more commonly referred to as a tripla. As you will remember, Dr. Boucher, this was by far the most commonly used regimen in the late 2000s. And then along comes dolutegravir, which was the latest and greatest integrase inhibitor and a true major advance in HIV therapeutics. And it was co-formulated with a bacavir dolutegravir, and that came as a single pill called Triumec. And a lot of people switched from a triplet to Triumec, and suddenly people were saying, oh my God, we're seeing this terrible weight gain with dolutegravir. I remember the first papers that came out, one after another, but the first group of them said everyone was so surprised because this had not been reported in the pivotal clinical trials. Well, it turns out that tenofovir FDC efavirenz is very weight suppressive. We now know this from multiple studies. And if you stop that regimen and replace it with practically anything, the people are going to gain weight. And they gain the most weight if you stop the TDF entirely and don't use any nucleosides. And that is one way. And the other way is by replacing it with TAF or even abacavir. And the integrase inhibitor may or may not be playing a role. These are some of the nuances we've learned. There is still some controversy about this. I have very smart colleagues who still think that TAF, in addition to not suppressing weight like TDF, like the original tenofovir, that it actually causes weight gain. But that's a much harder thing to prove. That's not been seen in all studies. Studies in HIV-negative people using pre-exposure prophylaxis comparing TAF with TDF showed that the TAF group gained weight about the much same as you would see in the placebo arm of a previous study of pre-exposure prophylaxis. That suggests that TAF in HIV-negative people is pretty weight neutral, and so in HIV-positive people probably is too. But we don't know. This is an area of ongoing research, and as Dr. Solomon mentioned, we invited, in particular, the senior author of this chapter, Dr. Kurtha, because he's such an expert in this area, and they outline some of these controversial areas.
I think what the authors do really nicely here is make the case that weight is an imprecise measure of what we really care about. Certainly, patients care about weight and the way they look, but what we should be thinking about from a metabolic standpoint is visceral adiposity. And BMI, which we currently use in clinic, doesn't necessarily distinguish between visceral adiposity and subcutaneous adiposity, and maybe sort of the wrong marker to be looking at. So other things that they propose are using things like waist circumference or waist to hip ratio, but we don't have a great way of measuring visceral adiposity at the point of care in the clinic.
Despite their very appropriately outline the difference between visceral and subcutaneous adiposity and the discussion about waist circumference, there are essentially zero HIV clinicians doing this routinely. I shouldn't say zero. There's a non-zero probably fraction, but they're mostly researchers interested in this area. It is something that you can get a surrogate for this by weight. Weight is still a very reliable surrogate for all the downstream complications. And the downstream complications we worry about, of course, are naturally things like insulin resistance, hyperlipidemia, cardiovascular disease. I have no doubt that excess weight gain in people with HIV will have those downstream consequences, even if it's not reported in a 48-week clinical trial.
Yeah, thanks. I was going to sort of get to that in terms of what do we know and what do we need to know about the downstream consequences. And I'm aware of some studies, and I know some of this is addressed, but what would you want our listeners to be aware of?
I think a couple of points I would highlight. The first is that, as Dr. Sachs already highlighted, when people gain weight, the rate of metabolic complications will go up. The precise sort of differences between regimens, I think people are very interested and we're learning more, but the general principle of weight gain goes up, metabolic consequences go up is going to be key here. I think the unanswered question is what to do about it. So there have been a lot of questions about, well, should we switch ART regimens to try to help people lose that weight? And that does not seem to be the answer. Certainly, if you go back to ATRIPLA, as Dr. Sachs had said, people will lose weight if they're moving from, an integrase-based regimen. But that's probably not best from a side effect profile and an HIV perspective. And so clinically, what should we be doing at the point of care? It's probably not altering the ART. It's probably thinking about ways we can help people manage weight and manage the metabolic complications. And there's quite a bit of interest in the use of weight loss medications like GLP-1 inhibitors and even gastric bypass.
Yeah, that's great. And in the era of GLP-1 inhibitors becoming the most expensive medicine in many populations, I think the importance of good study here can't be overstated.
Yeah, we've done. We in the field have done some helpful studies of GLP-1s in people with HIV, and not surprisingly, they work just as well, both in terms of improving things like the measures of diabetes control as well as weight reduction. And all of us who do longitudinal HIV care have been gratified to see our patients lose significant amounts of weight once they've started on GLP-1s.
That's great. Well, so this is an excellent discussion. Are there any other sort of, while we're on treatment and complications, are there any other complications or controversies you want to make sure we don't miss to call out here? I'll ask one. So just in terms of things that I'm asked as a non-HIV expert infectious disease person, the blip.
So a blip, if you mean just like a detectable virus between 20 and 100 on a one-time basis that then goes back to being undetectable, or even detectable but unquantifiable, periodically, that is of little consequence. It has to do with the high sensitivity of our assays, the fact that there's a long-lived latent reservoir, that there's a clonal expansion of this reservoir periodically that then gets detected. We don't do anything with those. What we struggle with are the small fraction of people with persistent low-level viremia. And the reason we struggle with it is because not only are we detecting it on a regular basis, usually between 20 and 100, but it has been shown to be of clinical consequence. There are more long-term complications. There's more virologic failures. And we don't know what to do about it, because when you intensify the regimen or switch it, nothing happens. And when you just try to reassure patients, they're not so reassured. And we think the same reasons apply. We feel like these are people with high baseline reservoirs, and we somehow just can't get rid of it. The good news is that it probably represents two different subsets of patients. One, a group who are very adherent, refill regularly. If you measure their blood levels of drugs, they'd be fine, and they don't fail with virologic failure and resistance. And then a second group who have something which sometimes is referred to as white coat adherents, who are good at taking their medications in the month leading up to their appointment, but may not fully achieve viral suppression by the time they get there. And it's probably that second group that accounts for most of the negative clinical outcome studies, and it's very hard to distinguish the two.
And one, I think, important point about those two groups, group number one that Dr. Sachs mentioned, the group that takes their medicines but has sort of a detectable viral load. We do consider those patients suppressed when we think about treatment as prevention. So we now talk about undetectable as untransmittable. A lot of our patients say, "What, my viral load is 32. Does that mean I'm undetectable or not?" And with that very low viral load, the likelihood of transmission is extraordinarily low.
Another area of controversy in HIV treatment is really what to do about ART during pregnancy. And this is covered very nicely by Doctors Espinal, Yee, and Fisher in their review. One One thing that's consolidated over the years is that we've become very comfortable with dolutegravir-based regimens, in particular with tenofovir and FTC or 3TC. So that's made the choice of ART easier during pregnancy. The harder thing is what to do when people are not on that regimen when they get pregnant. And here we have some increased clarity that if they're receiving bictegravir, FTC, TAF, we usually are just going to continue that because the safety data look pretty good for that as well. And then the issue of breastfeeding has changed. In the United States, we obviously counseled against breastfeeding, even if women were virologically suppressed. There were some really harsh efforts to counter the desire for breastfeeding among women who chose to breastfeed after pregnancy, including social service interventions and things that are really unbelievable right now. We now acknowledge that even though there's a non-zero chance of transmission from even a virologically suppressed woman, it's really not even as high as 1%. It's so low that it's still basically at the case report level. And as a result, now the guidelines say that breastfeeding in a woman who's virologically suppressed can be chosen by women on a sort of a shared decision making process, and that works really well, and that is something that is discussed in the chapter.
That's great. Thank you very much. And Dr. Solomon, you sort of bridged beautifully to the next topic I wanted to discuss, which is prevention, and specifically pre-exposure prophylaxis, which is a very hot topic, especially in the developed world. But I think it's also important to mention that in the world, we still have many, many persons with HIV who don't have access. And so the need for prevention is still a worldwide public health issue. So tell me a little bit more about the options we have for pre-exposure prophylaxis or PrEP and how clinicians should be thinking about these choices.
PrEP, I would say, represents the most significant advancement in HIV prevention over the past decade. And we now have many options or several options for patients. And we think about the oral options and some injectable options that are available now and one on the horizon. So the oral options are tenofovir-based regimens. There's TDF-FTC, which can be given on a daily basis or on demand around the time of exposure. And there's TAF-FTC, which is given on a daily basis. And when we think about those oral options, the TAF-FTC has not been studied well in cisgender women, and that's due to sort of a lower concentration of the metabolite in the vaginal mucosa, although a trial is ongoing. So we have the tenofovir oral-based options, and then we also have available the long-acting injectable cabotegravir, which is given as an injection once every 2 months. And in the large studies, HPTN 083 in MSM and transgender women, and HPTN 084 in cisgender women in sub-Saharan Africa, it was superior to the oral options, probably because it's a great medication and probably also around adherence issues. So now we have this long-acting option that we know is superior in the clinical trials, and yet a tiny proportion of our people who are on PrEP actually use cabotegravir, and I think that really speaks to some of the infrastructure and logistical barriers to getting people on cabotegravir. It costs a lot of money. You need infrastructure in the clinic. There need to be ways to bring them in and keep them in our orbit every 2 months. So we've had some experience in our clinic trying to set this up and recognize that there are barriers to getting people on this medicine. And then on the horizon, I think maybe we can just sort of talk a little bit about some of the newer data. And Dr. Sachs, maybe you want to talk about the lenacapavir data that's really exciting.
Sure. I mean, I think, because the chapter was written before the lenacapavir data were released, they don't specifically cover the results, but they do cover, research the next generation of PrEP options. And I want to say that we thought it was a real coup that we got Dr. Molina to write this chapter. Jean-Michel Molina is probably, among the top, I'm going to say 3 experts on pre-exposure prophylaxis in the world. And so he kindly agreed to do this chapter with his colleagues, Doctors Legion and Delaguerre. And apologies for my terrible French accent. Dr. Boucher, you probably would do better than I, given your last name. But I'm going to say that it's a great chapter, but no, he could not cover lenacapavir results. We basically heard this summer and saw it published in the New England Journal of Medicine, a twice-yearly injections of lenacapavir was 100% protective in women at high risk for HIV in sub-Saharan Africa. And then also, we just heard the other day that lenacapavir was 99.99% effective in preventing HIV among men who have sex with men and transgender women. So we have both populations covered with these large clinical trials that had blinded designs, really beautifully done studies. This is very exciting, and the FDA action on this drug is likely to happen within the next 6 months. So next year, we'll be faced with this dilemma where we have a very inexpensive tenofovir DF-FTC, which costs $10 to $30 a month without insurance. And then compared with these cutting-edge injectable treatments, which are significantly more effective.
And the clinical trial infrastructure for lenacapavir is not done. They have a couple of more. These are the PURPOSE studies. So we've heard about PURPOSE 1 and PURPOSE 2. PURPOSE 3 on the horizon is in cisgender women in the United States. And then PURPOSE 4, I think, is important. We'll be looking at prevention in people who inject drugs, which is another important population.
Yeah, that's great. Thank you very much. I mean, the advance here is absolutely stunning. And Dr. Sachs, I'm sure you remember 20, 30 years ago, the microbicide discussion, the various approaches that were being considered and advocated for, especially for persons in low and middle income countries who don't have agency. And so the fact that this can become such an option is really, truly groundbreaking. Last question I have here is back to your infrastructure comment, Dr. Solomon. How do you manage breakthrough infections? And even in, a first world health system that we have, infrastructure is an issue, and so
breakthrough infections are really, really tricky for us clinicians. And there are several categories of people that the authors of this chapter actually outline. So one category is people who actually had undiagnosed HIV before starting PrEP. The second category is people who acquire HIV that is drug resistant. And the third category is people who are non-adherent or intermittently adherent to PrEP, and then they get HIV infection. The third category accounts for the vast majority of people who have breakthrough HIV infection. And one thing we need to consider is whether people have drug-resistant HIV infection in the setting of people taking PrEP. And in that third category, most people get HIV because they're not taking the medicine. So most people don't have drug resistance. And so that's just, I think counterintuitive in some way, because you think people on PrEP who get HIV, they'll probably have drug-resistant virus, while most people who get it aren't taking the medicine. I think the very challenging piece is that people who are on long-acting cabotegravir or people who are intermittently on oral PrEP, it can really impact the dynamics of seroconversion. And so the testing can be really, really tricky in this setting because with HIV acquisition, if there's suboptimal drug levels, it can actually blunt the immune response, and you get sometimes discordant and confusing tests. And these are cases that we talk about with our colleagues and our friends and try to figure out what's the best way to manage this. In people who are on long-acting injectable cabotegravir, the recommendation for HIV screening is to use a viral load, a PCR test, which can be useful when trying to interpret some of these discordant serologies.
I'd like to just say that if you want to challenge a group of HIV specialists, tell them about someone on PrEP who has a reactive HIV test of any sort, whether it's a serology, antigen antibody test, or a viral load. This is not easy. This requires some very, very careful assessments, some checking the medication dispense histories, on repeating tests, sometimes, a very long, frank discussion with people on PrEP about really what their exposures were like. Are they really at high risk? Are they willing to come off PrEP for a while to sort things out? And if they do so, will they be taking protection during that time? I mean, these cases are anything but straightforward. In fact, one of the very best plenary talks I remember hearing at one of our CROI conferences was Dr. Molina talking about this. this challenge, and it's still a challenge.
Great. Well, thank you both. I mean, I'm so grateful for the breadth of the approach you took to this disease, which in less than a generation has gone from being a universal death sentence, for which we had hospice wards at the hospitals where we worked, Dr. Sachs, together, when I was a trainee back in the day, to a chronic disease for many, many people. I'm very grateful for your insights across the continuum of primary therapy, switching, side effects, weight gain, a hot topic in 2024, and then PrEP, and for all that you do for our patients. Thank you so much.
Thanks so much for taking the time to discuss these important topics, Dr. Sachs, Dr. Silliman, and Dr. Boucher. And thank you to our listeners for joining us for this edition of the Clinics Review Articles podcast series. For an exclusive discount on this issue we discussed today, focusing on advances in the management of HIV, visit us.elsevierhealth.com/expert. Infectious Disease Clinics is available for individual print subscription with accompanying online access, as well as individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 65 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on X, formerly Twitter, @Clinics Reviews and @ID Clinics, and subscribe to the Clinics Review Articles podcast wherever you get your podcasts.